the responsibilities of each member of the treatment team, and adequate documentation to justify the diagnosis and the treatment and rehabilitation services to be carried out. This is done by the interdisciplinary team, which does consist of the psychiatrist, program director, the registered nurse, social worker, and activity therapist. This team usually meets twice a week, but the level of care that we give, it's paramount that if we need to meet more, we will.
That's good. Okay. Well, what are some of the goals for the team?
Personally and professionally, we want to provide an environment that enhances communication. You know, in healthcare, when they are going from one unit to the next, pieces of information is missing at times. And if we have the full puzzle and we start that at the admission process and enhance that communication, it will really impact that care that's being provided, and when they're discharged, they'll be able to return to that level that the family member wants them to return to or hopes that they return to. We want to offer mutual support while enhancing the roles of each discipline and encourage education and training. I can't stress that enough with the staff. We want to be up to date, do our continuing education, keep current on medications and modalities that can be used. We want to assess and stabilize the presenting symptoms.
Okay. How does the team goals affect the patient?
Our team goals, I believe they go hand in hand, directly there. If we want to be successful as a team and our program to be successful, we want to help our patients develop new skills to improve their coping mechanisms. Now, we may get a patient and it may be undetermined of why they need extensive services or they need inpatient behavioral health. So we start at the beginning, we assess them, carefully assess them. When they first come in, not only are we looking at paper, but we're looking at the whole person. We're looking from top to bottom. So we're assessing, helping them improve those coping mechanisms. They may need help to develop those. Perhaps I may remind them of someone that maybe they had an encounter with long ago, and that may trigger something. Perhaps I remind them of someone that they are remembering, and that will help in the treatment process as well. We want to improve their daily functioning and integrate psychoeducation for the entire family as well. If we, our patients, we're providing the education for them, if we don't do that extra step, that extra essential step, then we're doing a disservice there as well. So we want to incorporate the entire family or those that are involved in the whole planning process. Developing that plan for support and aftercare resources is just, we need to get that started as soon as we can.
Oh, wow. Okay. Well, we will be right back to discuss the qualifications for admissions right after this.
Fayette Regional is your community hospital, serving the local area for 100 years. Founded in 1913, Fayette Regional has been providing great health care to the Whitewater Valley for a century and giving back to the community with outreach, support, and donations, as well as employing over 600 people in the local area. Fayette Regional, your community hospital.
Okay, we're back. Jessica, how does a patient qualify for admission?
To be admitted to the Geri Psych unit at Fayette Regional, they must have a psychiatric diagnosis. This also could include suicidal or homicidal ideation, imminent risk for danger to self or others, other psychiatric symptoms severe enough that can cause disordered, bizarre behaviors, or serious deterioration of a person's baseline. The inability to fulfill age-appropriate responsibilities is what the criteria would be.
Okay. Once a patient qualifies for admission, what kind of process is that?
It may seem like a lot at first, but we do it in an easy manner. Someone such as the spouse, the other facility, a different caregiver, they can call our unit. We'll ask them information, and I know sometimes if a family member calls in, they may not want to give out information.
Right.
They may not want to, confidentiality reasons, or mental health in itself has such a stigma. and they're reaching out. They need help. So we don't try to pry too much, but it is essential that we do get components answered when we do ask. We ask demographic information about advanced directives, the legal status, brief description of the patient's symptoms or presenting behavioral issues, their current medical status, any medications that they're on. We may ask if they've had any previous psychiatric treatment, and at times they are reluctant to let us know that. There's a misconception if they've been in other facilities or they've been someplace else that will mark them, or that they wouldn't be able to gain access to health care that way. If the call is coming from a facility, we'll ask them to fax some nursing notes with behaviors that's been documented within the last 48 hours. We'll ask them for any types of medications that's been administered, laboratory results such as a complete blood count, metabolic profile, and a urinalysis. We'll ask about any advanced directives. If they've had a psychosocial or psychiatric assessment, we will ask for those records. History of any previous psychiatric evaluations, any additional information pertinent to admission so that we can start from the beginning to try to help. Once we get that information, we relay that to the psychiatrist to make sure that the patient is appropriate. Our promise, because sometimes that call comes in, they're just waiting to try to get help. So our promise is 1 hour from the time of that call to get them an answer.
That's great.
If a patient is coming from another facility, and they're medically stable, we'll consider them a direct admit to the unit. For safety purposes, if they are coming from home, though, we do request that they go to the emergency room to get that medical clearance. Many times in the aging population, if there is something going on, such as maybe something as simple as a urinary tract infection, that can create some psychosis in the aging population.
Really?
Or if there's been some mixed medications and so forth. So we want to get that medical clearance just so that we know, because this is a behavioral health unit. Though we do have the 24-hour medical coverage, and we're taking care of those medical needs as well, we want to make sure that they are placed in the proper facility at that time.
Wow, I never even thought that, a medical condition can maybe offset a behavioral condition. So that's interesting. What is the average length of stay at the unit?
7 to 10 days is the average length of stay. However, that can differ from diagnosis and the reason for admission. So that's just a little timeline there.
What's a typical day like on the unit?
We have a highly intensive structured program. On our unit, we have a large board. We've already got it laid out as far as from the time they get up to the time they go to bed at night. Does it always get followed like that directly? No, because we do have the multidisciplinary team approach, and we also have individualized treatment planning. Therapeutic environment, we will always strive to provide that. We want to make sure that they're safe, that their basic needs are met, and then we go above and beyond to make sure that we are doing what they need at that time. Age-appropriate group therapy. If we had someone that was, for instance, 70 years old, we wouldn't want to put them in therapy for the group someone that's 95. They're on two different levels there. It can happen, and it does. The group therapy, though, it could be something as simple as playing bingo, really. Playing bingo or spirituality groups, or they may get out books and they talk about where they've traveled to, where they've been, those types of things. Individual and family therapy. We want that family involvement, so on a weekly basis we're going to be doing family support groups for them to come in if that's a need. Individual therapy, they'll meet. We do have a therapist that does come and do intensive therapy with them. The level of therapy would depend upon what their diagnosis is. Family patient education, we want to keep them abreast of everything that's going on while their loved one is in our care. Individualized treatment planning, like I had mentioned earlier. Yes, they may come in with a diagnosis of depression. Well, where did that depression come from? What is it stemming from? What's went on, the life events, and not one thing works all the time for one person. So sometimes it takes a little bit of time, and that's why we do that planning, so that we can. It's listing out things that are working for that one. Cognitive therapy, when we're building upon their strengths as far as their level of cognitive functioning. If we do get those that